Hey there, I'm Amy Connell. Welcome to Graced Health, the podcast for women who want simple and grace-filled ways to take care of themselves. I'm a certified personal trainer and nutrition coach who wants you to know your eating, movement, and body don't have to be perfect. You just need to be able to do what you're called to do. I am thrilled and honored that we have Erika Rucker joining us today. Erika is, I'm going to tell you a little bit about Erika here in just a second, but this is what I know. Women of Graced Health, I hear you. And we are 40s, 50s, 60s. So I am getting a lot of questions about hysterectomies. I do not have the answers to have about hysterectomies, but I have reached out and Erika is here to help us with that. So let me tell you a little bit about Erika. She's originally from New Orleans, Louisiana, but she's been in Houston the last 11 years. She was a high school science teacher. God bless the teachers in America. Oh my goodness. Prior to becoming a physician's assistant. She is with MD Anderson, which is just a world-renowned cancer treatment center. And she's in the gynecologic oncology department for 5 years. So in her spare time, she enjoys hanging out with her husband, her 2 kids. And she has a balloon and decorating business where she just spends her free time being creative, which I love that. Erika, welcome to the show.
Thanks. Thank you so much for having me.
Well, I said this before we got going, but I wanted to remember to say it again. I want to truly, truly thank you for your time coming on here. I believe it's your lunch break, and we are on our screens all day. So for you to give another hour of your time staring at a screen and talking with someone over video, I'm very grateful. My community, like I said, is thirsty for knowledge about hysterectomies. And I'm so grateful that you were just willing to come in and give us, talk with us a little bit about it today. So welcome, and thanks for joining.
Thanks for having me.
Okay. So you're a physician's assistant. You're in the oncological, and I just totally messed up all of those words. I'm sorry.
Okay.
At MD Anderson, and a previous guest, Jenna Unke, who talked about, I think that our episode was called "How Do You Know If Things Aren't Right Down There?" So she kind of came and talked to us a little bit about ovarian cancer, cervical cancer, uterine cancer, like all the things that we really need to know about that are not necessarily covered at our annual visit. So
Right.
if you have not listened to that episode, I've got the link in the show notes. Go check that out. But I reached out to Jenna because I said, I need some wisdom and some experts on hysterectomies. And she said, I've got just the woman for you. So that is how you and I connected. Now let's just kind of start high level.
Yeah.
Why might someone need a hysterectomy? And let's talk about what it is too. And my understanding is there's different types. So I'll just kind of pass the mic over to you and tell us, like, why do we need it? What are the different kinds?
Sure. Most of the time, I would say most patients need a hysterectomy for benign, we say not cancerous reasons. That can be for uterine fibroids, which are some non-cancerous growths that occur in the uterus, but they definitely can cause a lot of significant pain and bleeding. Uterine prolapse can occur sometimes. Prolapse is where this kind of slippage of the uterus into the vagina. So that can be another indication. Endometriosis is definitely very common, which is when the tissue from the lining of the uterus actually grows outside of the uterus and can again cause significant pain, infertility issues. There's also patients who experience just heavy or very unusual vaginal bleeding. And they've kind of exhausted all of their, non-surgical options prior to. And then, of course, cancer, pre-cancer reasons would be other reasons why patients would need a hysterectomy.
Okay. And that's a lot. Like, there's a lot of things that are in there. I mean, I appreciate the summary with that for sure. But I feel like I would assume, so I'll let you tell me if this is right or not, but I would assume that there are varying degrees and levels within each one of those of like, okay, is this the right course of treatment or is there something else?
I totally agree. I think I know, especially from our standpoint, hysterectomy is not our first go-to. It is a surgery. It's a major surgery, and it has implications that come with going under anesthesia and things of that nature. So we do like to exhaust our non-surgical options and ensure that a hysterectomy is right for the patient ultimately.
Got it. Okay. Now I have to confess that, so I'm 48 years old, and like I was really into studying my body and my, all of my gynecological everything when I was ready, when I was having children and babies. And that was important. That was an important part of getting pregnant. And I kind of like, I finished having babies, I closed the door on it, and I really haven't given a whole lot of thought to my uterus and my ovaries and all of that kind of stuff until now I'm getting into this perimenopause phase. And I don't know, I can't speak for anyone else, but that's kind of where I am. So one of the things that I don't feel like I'm very educated on, and I was wondering if you could help us, is understanding the different types of hysterectomy. So it's more than just taking everything out.
Exactly. Definitely. I think it's interesting when patients come to the clinic and we have this discussion and like, oh, I didn't even know that, so I think it's very common for us as women to not know exactly kind of what entails a hysterectomy. So a few different types. So the first one we'll talk a little bit about is what we call a partial hysterectomy. Sometimes it's also called a supracervical hysterectomy. So for most patients, I would say, or not everyone knows that the cervix, we kind of call it like a window to the opening to the uterus. So the cervix is attached to the uterus. So when we are doing a partial hysterectomy, you're actually just removing the uterus, but leaving the cervical. So it's supracervical. So leaving the cervix and just removing the upper portion of the uterus. I will say that one is not as common anymore. I think many years ago, it was very common to leave a patient's cervix, but ultimately we've seen kind of with a change in, educating and things of that nature. I believe mostly it was used for patients thought that by having your cervix allowed some, and this is kind of, we'll get more into this later, but allowed for no change in kind of sexual function or anything. But ultimately, that really is not the case. So I would say now partial hysterectomies aren't as common. What we say most of the time is what we call a total hysterectomy. So total hysterectomy means the surgeon removes the entire uterus and the cervix. And then there's also something called a radical hysterectomy, where the surgeon removes the uterus, the cervix, and then some tissue on both sides of the cervix and the upper vagina. But that is mostly for patients who is being treated for a cancer.
Got it. Okay. Now, are there any types that will also remove your ovaries or?
So, and that's, yeah, sure. Technically, the verbiage of total hysterectomy only includes your uterus and your cervix. Again, it's many misconceptions when patients come to the clinic or, we're having a discussion and like, I'm not even sure if my ovaries were ever removed. So actually the terminology for removing what we say tubes and ovaries is called a bilateral salpingo-oophorectomy. It's fancy words for saying removing both tubes, which is the salpingo, and then oophorectomy is the ovaries. But it's technically, it occurs sometimes at the time of your hysterectomy, but for some reasons we also, given the patient's age, sometimes we will definitely leave the ovaries in. So it's not always occurs at the same time as a hysterectomy. But I think patients and people really coin those terms together. When we say, oh, I had a hysterectomy, most people will think they also had their ovaries removed, and that's not always the case.
Okay, because that's kind of confusing, at least to me. Like to me, a total hysterectomy would totally take everything out, but you're saying that no, sometimes the ovaries remain.
Yes.
Well, this is interesting to me, and I don't remember what kind this person had, but next week I'm actually having a physical therapist on, and she's talking about like what to do after. So it's like, you've had a hysterectomy, now what? And she was 42 when she had her hysterectomy. So she decided to leave one ovary because she still wanted to cycle. She didn't want to lose all of her hormones and everything. So is there, I assume I think you said that age goes into that
Yeah.
decision on whether or not to remove an ovary or not.
Definitely. We, and we'll talk, more about these risks that come with removing your ovaries, so patients who are, we say the average age of menopause is 50, 51, but we have patients who go to 52, 53. So if we are removing your ovaries 10 plus years prior to when you would naturally stop, your ovaries wouldn't be functioning anymore, then there's implications that come with that. So patients who are younger, as long as ovaries look normal, they look to be healthy, there should be no reason that we would remove a 42-year-old woman, remove their ovaries, because they need their hormones for other reasons, which I'm sure we'll talk a little more about.
Sure. Well, yeah. Well, let's go ahead and step right into that. So talk to us some about risks of removing ovaries, maybe even risks with anything else. I mean, surgery comes with risks no matter what, but yeah, talk to us about some of that.
So whenever we remove our ovaries, technically menopause, or we say this perimenopausal state, when we go through menopause naturally, it's kind of this gradual decline of our ovaries, but losing function to our ovaries. But when we surgically remove them, then we're putting you in an abrupt menopause.
Right.
So patients can develop the hot flashes, the night sweats, the vaginal dryness, the decreased libido. But all of these things, though, we definitely have things we can manage with medications and lubricants and things. But some of the other things I think patients don't always think about is the increased risk of bone loss, cardiovascular disease, sometimes urinary incontinence. So, bone loss is really a big one, especially when we're talking about, removing ovaries in someone who is 10 plus years younger than the average age of menopause. So some of the things we recommend for, even if you're 45, if you're 52, whatever age you are, when you get your ovaries removed, bone health is extremely important, because even if you go through menopause naturally, you're still at this increased risk of bone loss. So we definitely recommend you take your calcium supplements, your vitamin D supplements, and do a lot of weight bearing exercising. So that's very, very important from a bone loss standpoint.
Okay. I feel like I interrupted you. Sorry. Did you have more?
It's right. Go ahead.
Well, what about, what about relationship or implications with any kind of cancer, increased risk of certain cancers, decreased risk if there is some? What about any of that?
So, of course, the risk of ovarian cancer for the general population is about a 1 or 2%. So, if you're not at an increased risk because you have a genetic mutation per se, a BRCA mutation, then technically removing your ovaries, of course, once you remove your ovaries, you eliminate the risk of ovarian cancer. But in the general population, if someone's going in for a hysterectomy, if you do not have a genetic mutation, then we don't believe you are at any increased risk. So we would not recommend removing your ovaries, if that makes sense.
Okay.
So removing your ovaries, again, most patients come in like, I just want everything out. But if it's not indicated, then typically we don't recommend removing your ovaries.
Is there any reason to keep your ovaries if you've already gone through menopause? No.
I mean, you've already naturally gone through menopause. So once we get to this gray area of like kind of age 50 to 55, it's definitely patient preference on removing your ovaries. But kind of after that age, then it's usually recommended that patients if they're having a hysterectomy, that they have their ovaries removed at the same time, because they're not functioning anymore. They're not providing us any hormones. So they could be removed at that time.
Okay. And that's just preventative, like
yes,
cancer? Okay.
Again, yes. Mm-hmm.
Okay. So I have heard, I've had a lot of conversations with people, and then of course I hear, I get DMs and stuff like that with people asking me questions, because I actually was like, hey, what do you want to know about menopause? So a lot of these are listener supported questions, which I'm so grateful for. I have heard people talking or asking the question about, having a hysterectomy. And again, it wasn't specified, but let's just assume a total hysterectomy, and the inability to manage body composition, and otherwise, will I gain weight after this? So are there hormonal changes that affect this? What can we expect, and how can we manage that?
Mhm. So definitely, if we're talking about a total hysterectomy where we're just removing tubes and uterus in the cervix, we would not expect any hormonal changes. But I'm guessing that you mean kind of total hysterectomy with ovaries also. So we say removing the tubes and the ovaries also, because we are now removing your ovaries and you now are not producing any estrogen. It does actually, data shows that it lowers your metabolic rate. So our metabolism definitely slows down after menopause. And when we're slowing down our after menopause, so that means we're not burning as much calories as fast as we would like to even lose weight. We have patients who come in and say, I'm doing nothing different than I was doing before, and I'm still not losing any weight. I'm still eating the same, I'm exercising the same. So it does, metabolically become harder for women as we age and go through menopause to lose weight due to the lack of those hormones. You also can start losing bone mass and gaining more fat because of that. So one thing I think it's interesting, and kind of as I've aged from my 20s to my 30s and having kids, and though I may be in a younger age group than kind of your audience here, but I think it's important for us to know that patients tend to say I'm gonna stop eating this or cut out eating this. And actually, as females, what I've seen and kind of in the data and things that I've read is that eating those smaller frequent meals as we age definitely helps our metabolism, helps our metabolism kind of stay more active, and then also increasing our protein intake. I think people don't always think about protein. You think about protein, you think about supplements and things like that, but that can be natural protein that we get from cottage cheese and yogurts and things like that. So definitely I've noticed increasing your protein intake and eating those kind of smaller frequent meals. Of course, physical activity goes a long way. We definitely recommend, if you can do 30 minutes a day for, 5 days a week or so, we definitely see that helps decrease, weight also.
Yeah. Okay. So I want to make sure that I heard this. So when we have our ovaries removed, that has scientifically been proven that we will lower our resting metabolic rate.
Yep.
Got it.
And again,
Okay.
it's not so much the uterus. It's not the uterus cervix. It's specifically the ovaries, because now we have a lack of estrogen.
Okay. And that's a hormonal thing. And that goes along, if I can put my personal trainer hat on for a moment.
Yeah.
This is why the strength training is so important.
Exactly.
Because strength training, when you add your muscle mass, whatever age you are, that will help your resting metabolic rate. And then at the same time, the right kind of strength training, which I'm leaning really heavily into creating a course on, like aging strong, but the right kind of strength training, like particularly doing a lot of pulling motion, will help prevent that bone loss, especially in your spine, to prevent that. I'm preaching to the choir. I know all of this, but I'm like,
I think it's important. I think as women, again, we tend to say, oh, I'm not going to do weights, I don't want to have bulky muscles, but really building the muscles, your muscle mass is so much, it's beneficial, very beneficial for us as we age.
Absolutely. I'm curious if you have recommendations when you talk about increasing your protein. Nutrition is all over the board, and it kind of depends on who you talk to and what they, subscribe to, in terms of eating philosophies. But do you have any guidance on, say I don't know, 55-year-old woman, how much protein should they be having?
I don't have a specific number on that. I know there's a kind of a formula that I've kind of been online, and even for myself, kind of determining when it comes to weight loss. But there's a formula you kind of can stick in your age and your weight and different numbers like that, and it gives you an ideal amount of how much protein you should be eating. I can tell you, sorry, and I know this is, give me 1 second. I can tell you for about 150 to like 200 grams, 150-ish grams for me right now is kind of what I've been focusing on. Kind of, so, and I'm 33 years old, but I think patients don't, or people in general, we don't really look at, if you sit down and kind of really look at the nutrition facts on everything we eat, and you're like, and really kind of put these things into MyFitnessPal, and at the end of the day, you see, oh my goodness, I'm not getting near as much protein or near as much carbohydrates, or different things like that. But a higher protein diet definitely is beneficial.
Yes. I have done the same thing. Every now and then I'm like, I wonder how much protein I'm having. And I just don't lean into that very much. I
Yeah.
like I could eat nuts all day and I'd be super thrilled. But I have to be super intentional about it. And yeah, I mean, I'm lucky if I can get like 0.7 grams per pound of body weight. So that's kind of what I go for, just because that's more realistic to me. Like there's no way I could get 150 grams. But that's just, that's it. That's fine. Like you and I are different. That's all right. Okay. So another question I had from my community revolves around nutrition. You mentioned a few things in terms of calcium, but is there anything that we need to be doing differently after a hysterectomy?
I think patients outside is something so important. We talk about calcium, vitamin D supplements, and I think it's something simple that we don't do much anymore. Whether we complain that Houston is hot or now it's cold outside for whatever reason, I feel like just getting sunlight, people don't understand the benefits that come from sunlight, vitamin D. Also, we talk about supplements so much, but when we're focused a lot more on getting a holistic approach of nutrients, balanced diet, then you also get a lot of the vitamin D, from the fish and different milks and things like that, different cereals or yogurts, different things. So definitely if you are unable to get the supplements in your diet, I definitely think it's important to take some type of vitamins over the counter, whether that's the calcium, vitamin D, but also just a regular multivitamin, kind of one a day, a women's one a day vitamin. I think it's really beneficial. I would expect that most people do not get as many vitamins and nutrients they need in their day-to-day habits of eating.
Right. Yes. I've heard that called nutritional insurance. So try and get it from your food, right, first, and then supplement and then supplement where else. And it's really funny that you talk about holistic eating. I actually have an interview, last week's interview with Ruth Opio, who is a integrative medicine counselor. So she's a licensed counselor, but also integrates medicine into that, like food and nutrition. So she says the exact same thing. So I love it when I have someone come on about mental health, and then I have someone come on about hysterectomies, and it all goes together. And I'm like, that's because that's the way that God wanted it to be. Like, it doesn't matter.
Exactly.
It doesn't, it doesn't matter what we're talking about. Like, the God's way will work.
I totally agree.
Okay. So I have like I said, I'm having a lot of conversations with friends about this kind of stuff. And I have a friend who was saying when she cycles, I think her cycles are regular, but when she cycles, it is hemorrhaging. And she said, like, after 15 minutes, I am soaking through a Super Plus tampon. And I mean, she's like, I can't go anywhere. And she said, I have talked to my gynecologist and said, I would really like to explore a hysterectomy. And the gynecologist was like, no, we're not going to do that. So our conversation kind of centered around, when is it right to get a second opinion or to question that? And when is it right to say, okay, you're the medical provider, I trust that you know more than I do, and just go on being confined to home for 5 to 7 days a month?
First of all, bleeding that much, we say, if you're soaking through pads within 2 hours, that's not normal. We say regular bleeding is bleeding every, it can last, for some patient, it could be 22, 28 days, 35 days, every 35 days or so. But, and then bleeding for about 7 to 10 days, anyone bleeding shorter than 21 days, lasting longer than 10 days, or like I said, soaking through pads, within 2 hours, that's not normal. So I'm not exactly sure what else this, if they've gotten an ultrasound and a possible biopsy, if they've tried other management things. So whether that's, we do birth control pills or IUDs, there's different ways to manage abnormal bleeding. So before, going to a hysterectomy, but if ultimately the provider is saying, hey, you're just going to have to deal with it, I definitely would get a second opinion. I think, we have to be our biggest advocates for sure. So it's important for just hearing that. I'm like, in my gut, I'm like, I don't think that's normal. I would definitely get a second opinion. If you feel like you've tried different things, you've exhausted different resources, and the doctor's still telling you, I don't think you're a good candidate, or this isn't something I recommend, I think it's always a good very good to get a second opinion. And again, abnormal bleeding, excessive bleeding like that is not normal. That is not normal.
Okay, that's good to know. Thank you for that.
Mm-hmm.
I think, especially for those of us who have grown up learning to respect our elders, saying yes,
Mm-hmm.
ma'am, no, ma'am, okay, that's what you want, and not questioning things, being an advocate for ourselves
Mm-hmm.
is really hard and uncomfortable.
It
Because
is.
we're like, yeah. So thank you for that permission. And I'm going to get off and I'm going to call my friend and I'm going to say, I think we need to go get a second opinion. And so does Erika Rucker.
Yeah, and I mean, if you, in your gut, you just have a feeling that something isn't right, I think it's always a really good idea to get a second opinion. Again, I don't know this provider, but sounds like this bleeding is not normal, and you should not have to deal with this every single month. Have to stay home for 5 days, 6 days of the month because of your bleeding is so intense. So,
right. And if nothing else, it's worth just getting checked out.
I totally agree.
Yeah. Okay. All right. So what kind of questions when we are in talking with our medical provider? I mean, this is a scary decision. This is like, we haven't even talked about the psychological aspects of feeling like, we may be losing a little bit part of our womanhood and stuff like that, which you feel free to address if you want. But what other kinds of questions should we be asking our medical provider before we making a decision with them to proceed or not proceed?
I think one of the biggest things would be, especially for patients who maybe have abnormal bleeding or pain or different things of that nature, I think we want to make sure that we have really, I want to say, exhausted our options prior to jumping into a hysterectomy. Because just as we stated earlier, a hysterectomy, with a hysterectomy also comes surgical risk, injury to bowel, bladder, anything in the area, and, reactions to anesthesia, cardiac problems. There's tons of things that come with surgery. So for most patients, I will say a hysterectomy is indicated. But I want to make sure that, especially I feel like in the community, there are providers who say, hey, you can just get a hysterectomy and go ahead, I'll perform that hysterectomy, do surgery for you, when it's not always indicated. So I definitely would say talking to your provider about making sure that you've really exhausted your non-surgical options prior to. And then there's the opposite end where there's patients who want a hysterectomy, and then the provider's like, yeah, I think we should wait. So like I said, and then getting a second opinion is always a very good idea. But I would say exhausting your non-surgical options prior to jumping into a hysterectomy.
Okay, that's really good to know. This is really good. And so if you're listening and you want to hear more about hysterectomies, tune in next week, because we're going to be talking about like from surgery on and what to expect there. So this is definitely a 2-part series. Like I told Erika before we hit record, I knew that this was way too much to go into in just one episode. Is there anything else I have not asked that you think is important that we know as we are learning to advocate for ourselves and as we are pulling in information to make the next right decision?
I think especially when patients get hysterectomies for whatever reason at younger ages, or even in our 40s, 50s, because that's definitely still very young. I think something that we don't talk a lot about is kind of sexual health, sexual function, dysfunction, should I say, whether that's vaginal dryness, painful intercourse. I think it's important for patients to have conversations with their providers about things that they can do, because there are things we can do. We have a lot of patients who come in and say it's been going on for years, but there's nothing, I didn't want to talk about it. I didn't feel comfortable talking about it. But that's one of the reasons you come to your provider, so if you're having the painful intercourse, vaginal dryness, decreased libido, that's something you should talk to your provider about. There is no fixed pill that we can just give you and be all, but there are definitely things we can do to try to help, combat those symptoms. Pelvic floor therapy is really good. Sexual counselors are really good. Vaginal lubricants, and there's tons of things, moisturizers. There's lots of options that I just think people are not always as educated on. So I think sexual dysfunction is a common topic that we see with our patients, that they just don't feel comfortable talking to their providers about.
Yes, that I'm really glad you brought that up. Thank you. Which actually leads me to another question kind of surrounding that is, I mean, does intercourse change at all for the woman or a man when you have a hysterectomy?
Technically, no. I mean, removing your uterus and cervix, we are not typically, I would say, we're not foreshortening your vagina or anything like that if it's for benign reasons. So there should be no changes, from a sexual standpoint. But when we also take your hormones away, the tissue is drier, it's not as stretchy, it can be more painful. So I think it's also a lot of kind of psychological kind of things that also take a role into sexual intercourse after hysterectomies, definitely.
Okay. But you're also saying if you're having problems, talk to your provider.
Talk to somebody. Yes.
Yeah. And don't be embarrassed. I remember Jenna, I think she said this on air, but she said you'd be surprised at how many like women in their 50s come in and on the intake, she's like, have you had, something about your sexual history or something like that, and just embarrassed to even talk about it.
Definitely. And again, going to your provider, it should be a safe place for you to have this conversation. But I also think it's important as we age, for females to be comfortable talking to their friends about these things too, because there are a lot of people and friends who deal with the same things and they just don't talk about it, and because they are embarrassed for whatever reason. But you will be surprised how many people are also going through what you're going through, and how you can also be a support system for those people, and even advocate, hey, maybe, because my friend told me this, maybe you should go talk to this person, maybe they could help you out, because we really shouldn't be suffering when there's things that can be done.
That's a really great point. And finding a community and other people who have been through that. It's just so helpful. It's so helpful to know like someone else is saying, yeah, me too. I'm there as well. Yeah. Definitely. Yeah. Okay. I have a few questions I ask all of my guests. One revolves around tattoos. So the deal is I am a crazy person, and anytime I'm out and I see someone who has a lot of tattoos, I will ask them about it, because I have found that when people choose to put something on their body for the rest of their lives, they often have a good meaning behind it. Sometimes, not always, but sometimes, most of the time. So I was wondering if you have any tattoos, if you would be willing to share one and what it is or the meaning behind it. And if you don't have one, but you had to get one, what would it be and where would it go?
I have one that says Serenity, Courage, Wisdom, actually on my foot. And I just remember growing up, that was kind of one of the prayers my mom would know. I would get upset, or something wasn't going right. My mom would always, kind of say that prayer and tell me that's what I should be thinking. So it's kind of one of the things as I age stuck with me. And I'm like, okay, I put it on my foot actually. And you see it, you think about it. And so that's one that's really important to me.
I hear the ones on the feet are boogers.
Yeah,
when you are getting them on.
Painful, definitely.
Yeah. I love that. Is that the God grant me the serenity
to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference.
Yes, love it. Yep. And so you just simplified it. I love it. Yep. Serenity, courage, wisdom. That's fantastic. Do you have a meaningful Bible verse that you would like to share with our community? We haven't talked a lot about faith, but
definitely when I was in PA school, physician assistant school, it was definitely a rough time, as in I was kind of isolated. I went kind of left my fiance and went to this Midland, Texas, and just definitely was, I guess, kind of alone in so many ways, but had, classmates, but it just is a different type of situation. And I remember every time I had a test, I would write this Bible verse at the top of my test. I used to get really anxious before tests. And so I can do all things through Christ who strengthens me. It's definitely one of Philippians 4:13, one of the Bible verses that is very important to me. So every test I would kind of write at the top before I got started. And I can only do what I can do. I can only do, and he'll see me the rest of the way through. So that one's important to me.
That's great. That's great. What a great physical or visual reminder too, when you're doing that on the test. Cause I relate to that. I do not take tests very well. Can you tell people how they can connect with you if they have follow-up questions, if that's even okay? I don't know how you feel about that.
Yeah, I don't mind. My personal email is Erika, Erika Boyd, BOYD, the number 11 at gmail.com. I also on Instagram, and I'm sure you'll kind of share those pages for so anyone can definitely reach out. I'm happy to answer any questions or direct you to someone who may be able to answer those questions if I don't have the answers.
Fantastic. Thank you for that. Okay. And then what is the one simple thing that you would like my community to remember? It can be something big, it can be something small, but just the one nugget to walk away from this conversation and remember.
I think be an advocate for yourself. I think as women, sometimes we tend to take the back burner on certain things and just say we can deal with certain things. And whether you feel like they're not totally normal or not, but being an advocate for yourself and really pushing through when something doesn't feel right, I think is very important. So be an advocate for yourself.
That's great. Okay. That